use case webinar presented by NYU Langone Health Systems on total joint arthroplasty bundle payment care initiative. This webinar is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. It's promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health to improve patient outcomes and value. The Davies Awards winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcome resulting from health IT-enabled care delivery. It is my pleasure to welcome Katie Malloy, who's the Senior Director of Care Delivery Transformation in MCIP and the Department of Network Integration. In this position, Katie is responsible for designing and implementing patient-centered, efficient, and quality-focused delivery of care, as demonstrated in the Bundle Payment for Care Improvement Initiative, which she led. Katie brings to this role an understanding of hospital operations, patient care workflows, and experience with a range of hospital IT systems and implementation. She has been with NYU Langone Health Systems for over 10 years. Welcome, Katie, and I'll turn the presentation over to you.
Thank you. Today. So let's get started. Today we're going to talk about our experience with the Total Joint Bundle Payment for Care Improvement Initiative and how Health IT supported our success in that program. That's the slide.
Let me put this on pause for a second. Let me pause this. Okay, you can move forward.
So our road to payment reform and network integration began over 10 years ago with our conceptual planning of our clinically integrated network and also our health information technology strategy. In 2008, we selected Epic as our enterprise-wide EMR. And in 2010, we created a payment reform steering committee with the focus of really helping us think about what was the best fit for NYU. Was it medical home? Was it bundle? So that was really focused on looking at our data, understanding our performance, and what was the best fit. In 2011, we selected our own health information exchange and started that. And we also, that was when the Medicare released the bundle payment for application. In 2012, we began our own clinically integrated network, which was focused on contracts. And we were also selected as a demonstration site for bundle. And in October of 2013, we started with the bundle, but we also had quite a few shared savings contracts come live around that same time. And that continued over the next several years the next few years, excuse me. And in 2016, we started a Medicaid shared savings and we also DSRIP program in 2015. So in the past, few years, there's been quite a lot of activity around preparing for payment reform, as well as putting our infrastructure in place around that. And today we're going to talk mainly about the IT infrastructure, but we'll also go through some of the governance around this as well. But really, again, to just focus here on this slide, you can see the different programs that we're participating in. So we have bundle payment, we have our commercial shared savings program, and our Medicaid IPA, of which we have about over 200,000 attributed lives. And then we have DSRIP, which is a New York State Medicaid delivery system reform program. Today we're going to focus on bundle payment for care and our experience specifically with total joint replacement. So what was our strategy around bundle payment? We considered quite a bit, and we looked at the data that CMS provided starting. And in looking at it, we felt that the places where we could be successful would be where things were attractive to CMS as far as being high volume. We felt that defined discrete clinical episodes that were relatively predictable were really the best place for this model. And the areas that we chose, total joint replacement, spine surgery, and CV surgery, we have very strong clinical leadership in those areas. Again, today we're going to focus on our experience with total joint replacement and how Health IT supported that effort. And what we're really trying to show you here is when we looked at our data, what were some of the outstanding levers that we knew that we needed to address. Mainly they were around readmission and high-cost disposition locations, such as skilled nursing or acute care. So if you look at this slide, at the bottom of the slide, you'll see black lines or black columns, and each one of those columns represents a patient episode. The black portion of it represents the index admission, and represents a readmission. Purple is inpatient rehab, orange is skilled nursing, yellow is home health, green is physician. So you can see that we do pretty well till about the middle of the slide, maybe a little bit less than that, and then you start to see a lot of variation with a lot of long stays and readmissions, so long stays in expensive facilities as well as readmissions. Here's a view of some of our baseline metrics. So for the initial post-acute setting, whether it was inpatient rehab, skilled nursing, home health, and outpatient, you can see what the 90-day readmission rate was, and also what's not listed here is the cost for each of these. Home health was clearly the least expensive cost of all. The cost drivers, as I mentioned before, that we really, looking at our own data, were able to pull out were some of the internal cost areas of focus were around length of stay, reducing implant costs and OR time, and then for the episode spend, it was really about readmissions, changing our discharge patterns, and for some groups, like later on we'll talk a little bit about our hospital in Brooklyn that joined Bundle in 2015, they have a skilled nursing facility as part of their portfolio, so it was really more about reducing the time that patients spent in the skilled nursing facility. Just want to, as I mentioned earlier, in order to be successful in changing culture, because that's really what we were needing to do to address how we were providing patient care, there needs to be a substantial support and governance within the institution. So we'll talk a little bit about how we set up for success with putting together the work groups and also the implementation of what was then deemed as care redesign, but also where that falls in the sort of broader organization around population health. So here you can see we set up, and for each one of the clinical groups for bundle or clinical areas, we set up this sort of a structure with a steering committee and then a pathway committee that was focused on care design in each of the three phases of the episode, so pre-hospital, inpatient, and post-acute, and then we have the cross-cutting groups below, which was EPIC, workflow, MCIT reporting, and implementation. With the joint pathway group, who were some of the leads around implementation? So there was the pathway committee, there was a specific implementation team, and then by discipline, there were leads in each one of those areas. So structure in place, and we knew that we needed to focus on standardization. So standardizing for 80% of the population was really the goal that we were aiming for, and we knew that by doing that we could improve efficiency, be able to really look at what were the individual factors that were causing us to go off pathway, if you will. Certainly, this improves communication, which was really key to our success. One of the big investments that NYU made in the bundle was around the role of creating a new role, which was the clinical care coordinator. And the clinical care coordinator is really the general manager of the episode, if you will. So they're looking at what's happening in each phase of care. So they're touching the patient pre-admission, they're following them in the hospital and working closely with the care team. And then they really are the main point of contact in the 90-day post-acute period or recovery period, if you will. And below we have all the different ways that we're communicating with patients and both with the care team. Again, another busy slide, but we'll talk through our technical workflow. So we'll start in the middle of the slide where it says EPIC. So bundle payment, the trigger or the way that a person is attributed to is really by the presence of a DRG. And what we learned early on was that we couldn't wait for the DRG to be coded at the end of the hospitalization. We needed to know well in advance when this patient would likely be a bundled patient, because we had interventions that we were setting up pre-hospital and around setting expectations pre-hospital that needed to take place. So what we came up with was at the time that a patient was scheduled for surgery, we created a DRG predictor that helped us understand whether or not patients were likely to fall into the bundle. And with 99% accuracy, we essentially that scheduling kicks off the predictor, which then puts the patient on the registry, which feeds physician dashboards and many other things. It also allows us to kick off a risk stratification for patients that may be at high risk for readmission. And again, this was an intervention that, or a tool that we implemented. So initially, everyone sort of received touch by the care coordinator, and what we, soon realized was that we needed a way to stratify the high-risk patients. So we were able to put that in place. And that feeds information to care coordinator, which allows them to kick off interventions as well, like a home visit by an occupational therapist, which would help us prepare that high-risk patient for surgery. And then we get to the clinical episode documentation, which includes documenting readmissions. So aware of the readmissions that are happening outside of our walls. So readmissions that are happening here are easy enough for us to report on, but those that are happening elsewhere, and certainly there are plenty of those, the care coordinators document that in the same detail that we would want to have on that report, and that information is incredibly important for us to have in real time. That's feeding both the physician dashboard and other reports that we use to understand our performance. So we didn't want to have to wait the 6 months to get that final claims data to know as much information as real time as we possibly can. Through our HIE, and we're going to talk in some more detail a little bit later about some of the ways that we're sharing information with our post-acute partners. You can see that we're also feeding Medicaid claims data into that episode documentation that's coming back to dashboards that we created. And then on the right side, we have MyChart, which is our patient portal. And there's quite a bit of activity that we have in MyChart. What we set up were clinical condition pages for each of the bundled conditions. And there's a number of things that are available for the care coordinator to activate with the patient for documentation of participation in a bundle, as well as the patient coach sort of agreement that we have with patients and their family members around supporting patients through their recovery or participating throughout their recovery. So moving a bit about some of the things that Health IT was able to support in the pre-care or the pre-hospital portion. So we're going to show you an example of the predictor, the care coordination dashboard, and what some of the reporting looks like around our high-risk identifier. So again, procedure report kicks off the DRG predictor, which then sets up this outreach that the care coordinator is doing on a daily basis. The patient gets flagged in the EMR as being participating in the bundled program. Data flow. So we see data into Epic. It's feeding the care coordination dashboard, which I'm going to show you in a moment. And then these are examples of the ways that the care coordinator is interacting with the patient. So these are some of the flow sheets that they're working through, and here's the MyChart portal. So here, care coordination dashboard, and this is really mission control for the care coordinator. And what the names that you see on here are not patient names. What they are care coordinator names. So you can see that if I were Judith Scott, I would have 28 patients that are in this pre-admission sort of area. So these are, I know that I need to make 28 pre-admission calls, or I have 28 pre-admission calls in my queue. Now those could be for patients that are being admitted 8 weeks from now, but again, this helps the care coordinator prioritize how she wants to manage that list. In addition, we have high-risk patients listed here, patients that were discharged, patients that are currently in the hospital, all patients. We have discharged patients by date. And then, as well as the initial calls that folks are receiving prior to hospitalization, there's also calls that are taking place on a weekly basis to patients once they're discharged. And the regularity of those calls changes with the acuity of the patient, but they're not only outreaching to patients and families, but also to facilities or home care agencies as well. So you can see that it's letting them know when the next outreach is. Readmissions are listed here. And the structure of this dashboard, these tiles were really evolved over time with the input of the care coordinators. Here's an assessment workflow. So this is some of the questions that the care coordinator would scroll through as they're making that pre-admission call. Pre-admission risk predictor tool. So you can see the red stop sign is letting us know that that patient is at high risk. This is the clinical condition page in my chart, which is the patient portal, which we talked about. The inpatient workflow, and what were some of the things that Health IT supported on the inpatient phase of care. So we are going to talk a little bit about order sets, some reporting examples. So we're in the conversation about standardization. So there was standardizing what happens pre-admission, and then on the inpatient side, there was a lot of different areas of standard and so it's not just how the patient is working through on the unit, but also what's happening as the pre-op standard, the intra-op standard, and then what's happening in the PACU. So around analgesia, that was standardized with a group of physicians as well as others. So this is one example. And then here is how it was translated into the record. To date, but just to give you an example. Also, there was an effort around VTE prophylaxis, so how do we address that and how do we standardize that? There were physician champions who spent quite a bit of time on this, trying to get consensus on how to move forward. And again, this has evolved over time, and this has changed, but this gives you an idea of what the effort was and what it looks like in the record. Here's an example of something that we put in place to reflect the patient's progress on the unit. So as you can see in this example, this is a patient who's post-op day 0. And what we did was we went by each domain of care and sort of said, we'll use pain control as an example. On day 0, what would be an acceptable pain score? We have the goals of care on the left-hand side. And you can see what's actually being documented. So whatever was most recently documented in the record is what's going to show up here. This tool is used by the care team, which is during rounds, which are led by the nurse practitioner. And they're sort of going through and saying, this is, I'm going through these domains of care to understand the patient's progress on a daily basis. And this has evolved over time as well. So you're able to see, previous pain scores as well. You can also see if the patient feels that the pain medication is helping them or not, or any satisfaction around pain control. And some other important things that we added were, for therapy, for instance, did patients refuse therapy? So the idea is that people can intervene immediately rather than waiting if there's an issue, and also see progress. They could potentially be discharged even sooner if they're meeting all their milestones. Inpatient census report that again is received by lots of key stakeholders on a daily basis. Now we're going to talk about some of the work that was done in the post-acute phase of care. So again, this was a key phase of care because what we were really trying to do here was change the discharge disposition. So the focus was really about getting more patients home than to facility-based care. So I'll talk a little bit about the post-acute documentation, and then I'll give you an example of a process that we set up with our post-acute providers, and then we'll talk a little bit about analytics. Here's an readmission report. So again, as I mentioned earlier, if there is an external readmissions, care coordinators are documenting it, and that is showing up here, as well as any readmission that may take place to our own facility. This discharge flow sheet. So when the care coordinator is making those calls post-discharge, they're going through a standardized flow sheet on how to approach that call, and they were set up by clinical condition. All of the documentation around the post-acute outreach that takes place. And again, another example of that post-acute, so they can choose the outcome and go from there. I made a really key area of focus in order for us to be successful, knowing that we needed to have close partners who were on board with the same goals that we had. So like we did in all the other phases of care, meeting with our own folks around standardizing and coming up with pathways, we did the same thing with our post-acute partners. And the partners were chosen for lots of different reasons, so geographics and obviously their star ratings and quite a number of criteria. And then what we did was we came up with what were the important things for us to be successful around patient care. So the focus was really on having some way that we could share information and also that we could keep each other updated on high-risk patients. And then things that we have put in place are a report card for the post-acute providers, and also we have regular quarterly meetings with them about sort of soup to nuts, what's happening with the bundle, their performance, our performance. And they often present best practices as well. So again, some of what we put in place for home care. So we had a standard pathway and then an enhanced pathway, and came up for the criteria of the folks that would qualify for the enhanced pathway, and it was really helped us establish a profile to determine the appropriate disposition. In our discussion of post-acute and show you an effort that we put in place around documentation that is a bidirectional communication, focus on our effort with the Visiting Nurse Service of New York, but in fact we have this in place with a number of other groups as well. But with BNSNY, we took it to the next level, and we'll talk about how we did that in a moment. So when we were meeting with the post-acutes, one of the biggest issues that they talked about was that they would get a lot of information at the time of discharge, and they would have to really comb through it to figure out what was important. And often discharged in the evening, and there wasn't really always someone that they could call to get the information that they needed, and it was crucial. So what we came up with was something that the care coordinators would initiate at the time a patient was being discharged, and we discussed what would be the information that they would like to receive, as well as on a weekly basis. So clinical status, functional status, and where a patient was. So knowing that people were on pathway as we had set up these expectations around what was to happen from a physical therapy and occupational therapy perspective, as well as a time frame of discharge. So you can see what the components of the transitional care communication tool were. And essentially, once the patient was ready for discharge, a care coordinator would get this documentation ready. And basically what we did was we leveraged our health information exchange. So I mentioned earlier that NYU has its own health information exchange, and we used a module on the health information exchange called EMR Lite, and we created this care form so that it would be completed by the care coordinator. It would be sent through the HIE, and it would be received by VNSNY. So they would log into their system, and they would be able to see that information. As well, they'd be able to then send back a follow-up form to us, which we showed you before, the components of what the follow-up form included. And then over time, what we did with VNSNY specifically was we took it to the next level, and we basically, and really where that came from was it was very difficult for the clinicians who really were the ones who knew the answers to these questions of how a patient was progressing over time. They were out in the field seeing patients. It was difficult for them to sit down and gather all the information about all the different patients that they saw on a specific day or time. And it was also hard for the NYU clinical care coordinators to know, I'm supposed to get a follow-up form on this day from VNSNY about this patient, and that day about this patient. So what we did was we standardized, that once a week we would get updated information, and it would come directly from the VNSNY EMR. So rather than them having to fill out these forms, we worked with them and mapped, what that information would be to what was the expectation for us. And then we went one step further and we brought that into our EMR. So this was a key process, and the care coordinators and the VNSNY staff are very pleased with it. To date, we've exchanged over 7,000 forms with VNSNY. So switching gears, here's an example or two examples of some of the information or the reporting that we've done around bundle. Again, these are focused on the key areas or the key levers for us. Here we're looking essentially at readmissions by discharge setting, and then readmissions really over time. And on the right-hand side, initially we had just been sort of reporting numbers on readmissions, and then we felt like it was really important for us to look at what was happening in the first 7 days, 14 days, and splitting it out because there were different reasons why people were being readmitted at different times. Here's an example of physician-level reporting. So again, we're looking at those key levers. So the average length of stay, the discharge disposition, and the 90-day readmission rate. This was extremely helpful, and we had strong leadership support for physicians to be able to see each other's performance. We added this conditional shading around the goals that were set up by the chairs of the department to say what were the expectations around home versus facility-based care, and certainly readmission. So now we're going to talk a little bit about some of our results. Before we get to that, I mentioned briefly earlier that our Brooklyn hospital joined the bundle in 2015, so we're also sharing their data with you here. So as you can see, this slide is showing us our discharge patterns essentially from 2013 forward, and our goal was to change the discharge disposition. Essentially what we did was we turned it around. So you can see that again, purple is inpatient admission, orange is skilled nursing facility, yellow is home health, and blue is self-care. And you can see from our baseline on the left-hand side at the Hospital for Joint Disease and Tisch Hospital, we've essentially turned around the facility-based discharge to home discharge with home and services. At Lutheran, they have a slightly different goal. As I mentioned, they do have a skilled nursing facility, so what they've done is decrease the length of time that patients are spending in that facility, and they've been very successful. And they've also started to send more patients home as well. So in light of changing the discharge pattern, we can see that the readmission rates have continued to improve. We do have a slight bit flip for the first quarter of 2017 and at Lutheran, and those were really related to hip fracture patients. So blue is total joints at the Manhattan campus, and orange is at the Brooklyn campus. And here we have the average length of stay, which continues to decrease over time. And I guess we're less concerned about length of stay, but certainly this was one of the areas that we did focus on. And here's an example of our cost savings. So this is a reconciliation running total. So from Q4 of 2013 when we started to Q4 of 2016. And in that time frame, for total joint replacement, we saved about $16 million, and you can see that averages out to about $1 million a quarter. And on the next slide, we can see that translates. We have total joint here down at the bottom, so we have it listed out by DRG, both for fracture and for no fracture, but it averages out to about a savings of about $7,000 a case, a little bit less than that. So all in all, a pretty successful program or initiative. And just to go over some of our lessons learned, continuous engagement requires a lot of time spending re-educating folks about reports and data, new goals and targets, and regular discussion of performance. We certainly learned that data is consumed and understood very differently by different groups, so we needed to have many different ways that we were displaying information. Leveraging IT platforms to identify populations of interest at pre-admission and during inpatient stay was key, and what we're really saying is to use the tools that you have. So the EMR, the HIE that we had in place, how do we leverage those tools? Obviously, early identification of patients was critical to our success. Placing focused information in the hands of clinicians in order to work on the care design was very helpful, because what we were able to say when somebody would say, my patients are different, we would be able to say, no, these are your patients and this is what's happening. Develop tools to stratify patients allowed us to target our clinical interventions, and we talked a little bit about that. It really helps us streamline our resources. Something I didn't mention before was that we developed and worked for quite some time with our care coordination workflow manually before we built it in Epic. And this was key to really help us focus on what we needed. And relationships with our post-acute partners to expand care delivery, like our example of what we did with CNSNY and with some of our others was really a key to our success, but also was very much appreciated by the clinicians on both ends. And again, the concept of bundle is still very new, but the idea of bundle for procedural-based care seems to be catching on, and we've had certainly an interesting experience and have learned a lot along the way, and Health IT has been foundational to the success of this initiative.
Thank you, Katie, and thank you for joining us today for this Davies webinar. More Davies use case webinars, information on how to apply for the Davies Award can be found posted at the HIMSS Davies Award website at hims.org/Davies. That is a wrap.